definitely we can get the benefit of listening Dr. Achintya Das. Thanks, Dr. Das, for accepting our request and being taking the part of this evening as a speaker on many anorectal disorders, the affairs, the managements. So I really thankful to all of you. My sincere thanks to all the participants for being there, taking out the time out of the busy schedule and the kind of scenario we are ongoing scenario we all are undergoing. I request our medical head, Dr. Gurnath, to take it forward by giving a formal introduction of Dr. Achintya Das.
Yeah, thank you, Mr. Thank you, Mr. Santul. Once again, I welcome all of you on behalf of Samarth Life Sciences, and special thanks to Dr. Achintya Das for accepting our invitation and selecting the topic. The topic to cover the 3 disorders in 1 hour. It itself is a challenge, and I really appreciate sir for taking the challenge. To give some information about Dr. Achintya Das, although Debashish has given some information about sir. Sir is graduated from Calcutta Medical College and he has done his post-graduation under Calcutta University. Sir is having nearly 2 decades of experience in the field. He has special interest in advanced laparoscopic procedure, and sir is currently associated as Professor of Surgery at Ramakrishna Mission Seva Pratishthan, Vivekananda Institute of Medical Sciences. Thank you so much, sir, for accepting our invitation. A request to our all delegates, if you have any question related to the topic, please put your questions in the Q&A so that we can take this question to sir. Thank you so much once again, and over to you, sir.
Thank you very much. First of all, I thank all the participants who have joined in this webinar, and my colleagues, my friends, my seniors, and also people from Samarth Life Sciences who have given me the opportunity to speak in this topic of anorectal disorders, which include hemorrhoids, anal fissure, and anal fistula. I think before we go into the topics, into the PPT, let us first understand that whenever we are in our surgical practice or medical practice, whenever we are dealing with the patients, although it's in the time of this COVID-19, things have changed on telemedicine, but still when we were dealing with the patients, what is important is an important history taking in making your diagnosis in surgical diseases. And what is important is whenever you see a patient coming to your chamber who has with the difficulty of even sitting on the couch, sitting on the chair, difficulty in lying down, complaining of pain during defecation, and that pain persisting for more than 1 hour, 2 hours post defecation, and a burning sensation after defecation, your diagnosis is already made when you have taken the history. It's a case of anal fissure. Sometimes when someone comes with the history of a bleeding PR or a painless bleeding PR, sometimes the patient says that I haven't noticed any bleeding, only my wife or my daughter or my son told me that my underclothes or clothes are stained sometime, and after being told, I have noticed that I have passed blood, and sometimes I feel there is a perianal leaching, sometimes something comes out for the rectum. Then your diagnosis is made that it is most probably a case of painless bleeding per rectum, is most probably a case of piles. Yes, piles sometimes becomes painful when it gets thrombosed, gets strangulated, but painless bleeding PR is always an example, is a indication of a hemorrhoids. And when patient comes with a past history of a perianal abscess that has been drained, and now he presents with a recurrent swelling at the site of the heel scar, or complains of discharge from that area, and he complains of a regularity of things that the swelling comes up when there is a and there is a swelling, there is no discharge, and after the discharge the pain goes off and he feels comfortable. So the diagnosis is anal fistula. So these are the three common things that we are going to discuss, and we are going to discuss the surgical anatomy, some symptoms, and the management. But history taking is a very important part, and that also is a examination of that. So let us start with the first slide. Vishal, please. So we are starting with the hemorrhoids. The uh, the hemorrhoids are this basically, these are the vascular cushions, and they get these are the vascular cushions at the and the hemorrhoids are due to the sliding of the vascular cushions. You can see the columns of Magagni, the vascular cushions, when they slide down on constant straining, or due to constipation, due to increased intra-abdominal pressure, which may be due to a pelvic SOL, or maybe due to pregnancy. This columns slide down, and these columns consist of blood vessels, the arterioles and the venules, the supporting connective tissue, and there is a mucous membrane, and this is what we known as piles. Next slide. Next, please, Vishal. So it has been found, a study undergoing colorectal cancer screening, that there is 39% prevalence of hemorrhoids, and 55% of these they are asymptomatic. And if untreated, they can potentially pose serious medical problems and can be a symptom of bigger problem. And they can be seen at any age and in both genders equally. Next. Next slide. So as you see that distribution of patients according to age, there's 20 to 39, 40 to 59, and then incidence of hemorrhoids according to the occupation. Patients doing manual work, hard labor, also patients doing in our present times, patient who doesn't got a normal bowel habit, they are doing night shifts. People working in the BPOs, they are the ones who are having this sort of problems. Next, please. Next slide. So the incidence is again about the hemorrhoids based on hereditary. There is some hereditary incidence of hemorrhoids in the males, and based on the type of constipation. Next, please. So what are the presenting symptoms? As we say, it is bleeding through the rectum. That is painless bleeding to the rectum. There is sometimes the patient complains of he feels a mass, that is something coming up the rectum. Sometimes there is soiling of fluids. Then there is pain during defecation, but the pain is a lead feature, or when there is a thrombosis of the piles, or when it is a circumferential piles, then only the pain, and there is associated infection, then only pain comes. And sometimes there is this symptoms of perianal itching. Next slide, please. Next.
Yeah.
So the primary etiology, as we have said already, that is the excessive straining during the constipation or diarrhea. So this straining causes the downwards or the sliding of the vascular hemorrhoidal cushions, leading to the disruption of the supporting tissue elements with subsequent elongation, dilatation, and engorgement of the hemorrhoidal tissue. Now this tissue of this hemorrhoid, these are the blood supplies of the terminal branches of the superior rectal artery. There is one on the left side and two on the right side, right posterolateral and right anterolateral. We say this if the patient is in a lithotomy position. The one on the right side is the 3 o'clock, one on the left side is the 3 o'clock, on the right side is the 7 o'clock, and the 11 o'clock piles. Now, the other conditions that contribute to the formation of the hemorrhoids is, as we have already discussed, is an increase in intra-abdominal pressure that may be caused by pregnancy in females, ascites, or presence of a space occupying lesion in the pelvis, which causes concomitant disease in vascular return and increase in anal vascular engorgement. Next, please. Next slide.
Yes.
So the classification of the hemorrhoids, the external hemorrhoids and the internal hemorrhoids. External hemorrhoids are those which are located in an area distal to the dental line and covered by the sensate anoderm or the skin. The hemorrhoids that originate And the internal hemorrhoids are the four grades that originate proximal to the dentate line covered by the insensitive transitional epithelium. That is the grade 1 when there is protrusion that is limited within the anal canal. Grade 2 is that protrudes beyond the anal canal but reduces spontaneously. Grade 3 is protruding beyond the anal canal and needs manual repositioning. And grade 4, it remains protruded outside the anal canal and is reducible. Now, these all grades are according to next slide, please, Vishalji.
Yeah.
This is the classification of the internal hemorrhoids by the American Society, and this is all the same things. Grade 1, 2, 3, 4. That is, they have added it with the Valsalva procedure. There is prolapse and spontaneous reduction. Grade 3 is the prolapse with the Valsalva procedure and requires manual reduction. And grade 4 is chronically prolapsed. Next slide. The association. Next slide, please.
Yes, sir.
The Association of Colorectal Surgeons of India has added with the grade 4, there are another A, B, C, D symptoms. This constitutes, depending on the number of piles, how the circumferential the piles, or there is thrombosis. So the grade 1, 2, 3, 4, which we have already discussed, are that is remaining inside the anal canal, that protrude during defecation or reduce spontaneously. Grade 3 is need further manual reposition, and grade 4 is piles that remain prolapsed. But the other A, B, C, D is a single pile mass. B is two piles mass, but they are involving less than 50% of the circumference. Grade C is circumferential pile mass occupying more than the half the circumference of the anal canal, and grade D is the thrombosed or gangrenous piles, so the complicated piles. So these are the A, B, C, D of the variation, which is added by the AC Association of Colorectal Surgeons of India. Next slide, please. Next.
Yes, sir. Yeah.
So what are the so according to the grades, the management that is there. So whenever the patient comes to you, most important is diet and lifestyle modification, of which diet you have to insist on the patient that you have to have a high fiber diet. Your fluid intake is according to your body build and body habitus, around 2.5 to 3 liters for an Indian adult male or a female. And then for grade 1, we have the medical therapy, preferably the micronized purified flavonoid fractions. And if it fails, then there are non-surgical procedures. For grade 2 is again diet and lifestyle modification, as we have said, that you have to, one is having a high fiber diet, a good oral intake of fluids, and avoid constipation, a regular bowel habit. I think that is one of the important things that you have to ensure in that patient's regular bowel habit. And then again, the medical therapy with micronized flavonoid fraction. And then if they fail, there is non-surgical office procedures like rubber band ligation or injection sclerotherapy. And the grade 3 and grade 4. Grade 3 are the or grade 4, you have to go for the surgical procedures. The office procedures will come later. Next slide, please. So this is, we have already discussed the increased fiber intake with adequate fluid as a first line treatment. And if constipation is a predominant factor, you use laxatives like polyethylene glycol, lactulose, or the bulking agents. Next. So medical management means micronized purified flavonoid fractions. This is recommended, and the dose is 1000 milligram per day for an adult. In an acute setting, in an acute bleeding hemorrhoids, you have to make this 1000 milligram thrice daily for the first 4 days, followed by 1000 milligram twice daily for the next 3 days. This can manage the acute system. And another thing that we didn't say is, when it is a prolapsed or a thrombosed hemorrhoids, always it is very important grade 3, grade 4 hemorrhoids, you can always ask the patient to have a seize bath, that is warm seize bath, having a lukewarm water with betadine lotion, and to put your anus under the water for 5 to 10 minutes till the water remains warm. So it is a part of the conservative measurement. Next slide, please. Other existing venoactive drugs can be used like calcium dovacilate, heparan sulfate, euphorbia prostrata, ginkgo biloba, but they have a low level of evidence in the management. The long use of topical products like preparations containing steroids should be avoided due to their detrimental effects. I think this is very important. Steroids have a detrimental effect and they should be better be avoided in piles. Next. So rubber band ligation and injection sclerotherapy and infrared coagulation may be used in treatment of grade 1 and grade 2 and selectively grade 3 hemorrhoids. The success rates are highest with rubber band ligation with complication rate. Now, rubber band ligation is office procedure where you do a proctoscopy, see the hemorrhoids. You can hold the hemorrhoids and just push a rubber band, and the rubber band decreases the blood supply to the hemorrhoids, and that causes the hemorrhoids to uh, then fall off, or the hemorrhoids shrink in size. Injection sclerotherapy, next slide please, is one of the important um, uh, office procedures where you form a foam injection was performed with polydoconol 20%. The foam injection is you take a three-way cannula, you take a 21 gauge syringe, you inject with the 10 cc syringe, you take 2 ml of polydoconol and 8 ml of air, and in two sides you connect the 10 ml syringe, and the number of sessions. But what you have to explain to the patient before you do it is to the patient may need 2 or 3 sessions for complete cure, and also there will be initially a little bleeding, but that thing slowly passes off. The efficacy is very high, and 98% reporting satisfaction regarding loss of prolapse reduction. So objective reduction of prolapse volume was documented 86% in re-observation studies. Next slide, please. So next, please. So treatment of now this is the procedure where you are using that injection polydiconol, and 10 ml of which with the polydicol foam in high doses is very effective and safe. So it is a very effective method where you can control the grade 2 and grade 3 and early grade 4 hemorrhoids. And in some patients where you do not want to operate, like patients on anticoagulants, many of the patients are elderly patients, cardiac patients on multiple anticoagulants where surgery is a high risk procedure. There this foam sclerotherapy is a polydoconol is a very important, where we use our ascarol and we get good results in that. So next slide. Next, please. So it is the how we are doing it. The 2 ml of liquid sclerant and then 8 ml of air. Now make the plunges of both syringe back and forth, make a foam, and you inject the foam with a 21 gauge needle into the submucous of the hemorrhoids. There will be blanching of the hemorrhoids, and you know you are in the right plane. The patient may complain of a little pain, 1 or 2 bouts of reddish stool can come out, and what you have to explain to the patient is that this procedure may need repetition. Next slide, please. So then we come to the surgical management of hemorrhoids. Surgical management of the hemorrhoids are excisional methods. Here they have given hemorrhoidectomy and stapled hemorrhoidopexy. Excisional methods and hemorrhoidectomy is for grade 3 and grade 4. We have the closed procedure of hemorrhoids, which is the Ferguson method, and the open method like the Milligan-Morgan method, where it is very important to understand and to go to the base of the piles and to ligate the piles or use the newer armamentarium of the surgeons like the ligature or the harmonic scalpel or the monopolar or the bipolar modes of electrocautery, so that we can and also there is the Park's method of submucosal hemorrhoidectomy that you can do. Next is the stapled hemorrhoidopexy, that is recommended in the treatment of the grade 4 hemorrhage where there is a prolapse. Compared to the conventional hemorrhoidectomy, the hospital stay is less, the pain is less, the pain after a hemorrhoidectomy, because that area of where we are operating below the dentate line, it is supplied by the inferior rectal nerve, which are the branches of the internal pudendal nerve S2, 3, and 4. So this area are very painful. So in stapled hemorrhoidopexy, you can avoid this pain. You can use a stapler and you can take bites all around with proline, and then you can staple and cut through that mucosa and take the prolapse mass of the hemorrhoids. This should be always done under a spinal anesthesia, and it should be very, very careful when you have done the staple hemorrhoidopexy. Please check after doing the hemorrhoidopexy when you take the two ends of the stapler, the cuff, whether the downwards are equal or not. That is very important to check the efficacy, because one of the complication is of a staple hemorrhoidopexy is torrential bleeding, and this bleeding is at a site which is quite high, where which you cannot approach from below and which is difficult to approach from above. So it is very important when you take the purse string suture along the anvil of this stapler. The purse string suture you take is of equal depth, and you are very sure that you have tied it. And when you fire the stapler, you should be very sure to hold the staple gun for 1 minute and see that there is no bleeding. And these are two excisional hemorrhoids. Next slide, please. Then this is the non-surgical method where you can use the Doppler guided hemorrhoidal arterial ligation. This is Doppler guided hemorrhoidal arterial ligation where you tie the terminal branches of the superior rectal artery by a handed Doppler, where you can just find out the artery. You can by the sound you can identify the artery and you can tie the artery, and this will result in shrinkage of the piles. And this is, although the recurrence of grade 3, grade 4 hemorrhoids may be a limiting factor, a combination of anopexy or mucopexy with Doppler guided hemorrhoidal arterial ligation, because the recurrence rate in Doppler guided hemorrhoidal arterial ligation is about 17%, 17. So it has to be associated with other methods like anopexy and mucopexy to decrease the recurrence rate. Next. Also, there is the newer method is you can use lasers, diode lasers for hemorrhoidal excision, and this has come in vague recently, and it has been used in some places, but these are costly procedures. But with time, these things are being used. Now, hemorrhoids in special situation, as we have said, in on anticoagulants, the better is to use with cardiac compromise. Injection sclerotherapy is the procedure of choice. Patients infected with HIV, conservative treatment is the first line approach. If conservative treatment fails, then surgical procedures should be offered with proper CD4 counts and prophylactic antibiotics. Hemorrhoids in pregnancy, all symptomatic hemorrhoids should have a conservative approach, including diet, laxatives, and lying down. This micronized purified flavonoid fractions are safe and effective in pregnancy, but in the second and the third trimester, the first trimester, you should better avoid them. So in pregnancy, you have to always do the conservative treatment and do the any surgical treatment if required after confinement, after the baby is delivered. Surgical procedure should be reserved for thrombosed piles and performed under local anesthesia. I think local anesthesia is what we call a saddle block, but still you have to explain to the patient party in a pregnancy that there is whatever sort of anesthesia you give, even if you avoid general anesthesia, regional anesthesia like a saddle block, they can cause a premature onset of labor. So that has to be explained. Next slide. Hemorrhoids in special situation. The conservative approach of hemorrhoids. Whenever you are faced with a hemorrhoids, a circumferential hemorrhoids, you see big piles mass at 3, 7, and 11 of clock position, and they are engorged. They are looking very, because then you must be very much aware that this might be a case of portal hypertension. If it is a male patient, please go back and check whether the patient has gynecomastia. If a male patient, whether there is gynecomastia, there is loss of body hairs, axillary hair, pubic hair, or there is associated ascites, spider angioma. These things has to be checked. And in portal hypertension, really, if your hands are not tied, do not go for surgery, because this area of the hemorrhoids, the dentate line is a line of portosystemic anastomosis, because above the dentate line, all are drained into the superior rectal vein, which drains into the portal system, inferior mesenteric vein. But below the dentate line, the blood drains into the internal ileal vein, which is a systemic vein. So stapled hemorrhoidopexy is a good option for portal hypertension patients, but this has also to be done with utmost care. And hemorrhoids in children, dietary habits, proper toilet training, and medical management line are the first line of options for hemorrhoids, and non-surgical office procedures may be done. Next slide, please. Now we come to the anal fissure. Now, as we have said, that whenever these three situations we are examining, we have to take the history. When we have taken the history, and after reassuring the patient that you have will not cause pain to the patient, when you do the examination of the local area, when you do an examination of the local area, the first thing when you do is with your gloved hands, when you stretch the buttock and stretch the anal opening, if the patient has pain, and you can see a linear tear in the anoderm, in the lower one third of the anal canal below the dentate line, this is a case of anal fissure. In case of a chronic anal fissure, you can see with that anal fissure, there is a edematous skin tag along with it, which we call sentinel piles, and internal outside, and internally you can see a hypertrophied anal papilla. And in a case of anal fissure where you are stretching the two buttocks, the patient is writhing in pain, please do not do a digital rectal examination or upper rectal examination. Avoid from doing that. In that, you are not gaining anything, you are causing pain to the patient, and you can worsen the situation. And while doing, because all these three things require a digital rectal examination, you need to understand that what you are going to find. While doing the digital rectal examination, you need to put lidocaine or a lignocaine jelly, 2% lignocaine jelly into that local area, and wait for at least 30 seconds to 1 minute. Talk to the patient, explain to the patient that you are going to do an internal examination, reassure him, then slowly put your hand inside. The first thing you see is the resting anal tone. If the resting anal tone is high, that the sphincter is very tight, your diagnosis is basically an anal fissure. If the resting, then you do not proceed with the rectal examination or the proctoscopy. But if the resting anal tone is normal, then you can put your hand in. You can put your hand in a male patient anteriorly. You can assess the prostate. You can assess the rectal mucosa. You can put your finger up to the area that it goes. And when you take out your gloved finger, you can see the condition of the rectal wall, the anterior and the posterior rectal wall, whether there is a blood in the fingertip, whether there is any protruding mass or anything, and whether you can palpate the inner opening of an anal fistula, which will appear like a grain of rice on your hand, and whether there is any other submucosal abscess or bulging in the perianal skin, in the immediate perianal skin. So that is the physical part of the examination that we do. Let us go on to the anal fissure of the PPT. Next slide, please, Vishalji. Anal fissure is an ulcer-like longitudinal tear in the midline of the anal canal distal to the dentate line. And this is, as we said, the dentate line is the watershed line. Above it, like the venous, as we have said in the hemorrhoids, the blood supply, the venous supply is above it is to the portal circulation, below it to the systemic circulation. Above the dentate line, the blood supply is by the parasympathetic supply, but below the dentate line it is supplied by the inferior rectal nerve, which, and that area of the anodome is very sensitive. So and that area, whatever you do, you have to be really sedate the patient, or you have to really anesthetize the patient. In almost 90% of cases, an idiopathic fissure is located in the posterior midline, but it can also occur in the anterior midline. And fissures in the lateral position should arise the question of other diseases like inflammatory bowel disease, like mainly Crohn's disease, tuberculosis, syphilis, HIV, or dermatological conditions like psoriasis or anal carcinoma. Next. So the causes of anal fissure, constipation is one, again chronic diarrhea is one, then tuberculosis, inflammatory bowel disease, mainly the Crohn's disease, HIV, anal cancer, childbearing, previous childbearing and a complete perineal tear may be cause of, and a poor repair may be a cause of anal fissure, and a prior anal surgery and anal intercourse may be another cause. Next. An acute fissure looks like a simple tear in the anodome. Acute anal fissure is thought to be due to passage of hard stools or sexually transmitted disease or anal injury due to penetration. So it may be seen. A chronic fissure is one that is defined as lasting for more than 8 to 12 weeks and is characterized by a part of a sentinel piles, as we have seen, and the edematous skin, hypertrophied skin, and also on the inside there is a hypertrophied anal papilla. The anal valve becomes hypertrophied. It is the anal papilla. Approximately 40% of patients we present with acute anal fissure will really have the painful symptoms. Next slide, please. Next. The anodome refers to the epithelial component. It is inferior. It is very sensitive to microtrauma and a tear from repetitive. The high pressure, it can result in delayed healing due to ischemia. The tear sometimes can be deep enough to expose the sphincter muscles. In some cases, when you are exposing the two buttocks, you can see that there is a tear, and together with and you can see the tear, and below the tear, you can see the internal sphincter muscle. This creates severe pain with bowel movements as well as some rectal bleeding. The patient complains of fresh bleeding PR and a tremendous pain perianal region during defecation and after defecation, and this pain, this burning sensation persists for 2 to 3 hours. Next. The clinical hallmark of anal fissure is pain during defecation and often post-defecation. Often there is a history. The patient will give you a history, tearing sensation during passage of hard stool or diarrhea. Rectal bleeding is slight and limited to minimal bright lead color on the toilet tissues, or patient will say when I wash that area, there is a small drops of blood that comes out. Next. So that is one thing, as we have said, doing the digital rectal examination, you have to really comfort the patient, gain the confidence of the patient, tell him that you will not cause any pain to him or her, and then examine the patient. If the fissure is acute, it resembles a paper cut. Fissures that are more chronic tend to be wider, have indurated margins, have visible transverse fibers of the internal sphincter at their bases. They are mostly seen in the posterior midline and sometimes in the anterior midline in females, sometimes in the lateral positions. And when they are in the lateral positions, your diagnosis should go to tuberculosis, Crohn's disease, or anal carcinoma, because lateral fissures are not very common. A digital rectal examination should not be performed. This is very important. This is a very important takeaway message. Next. Next. So anal manometry should be considered who have obstetric or third degree complete perineal tear, as resting pressure can contradict the need of sphincterotomy. Ultrasound examination is a useful adjunct to manometry in this population to identify anatomical cause for lower anal sphincter measure. Next. But anal fissure is basically a clinical diagnosis. So when the recommendations are, gastroenterologists and other providers should use operative uh, um, uh, the treatments like a Cis bath, the fibers or bulk agents as the first step of therapy in acute fissure. So the therapy is again the Cis bath, again having your stool soft and having high fiber diet and a good fluid intake. Next. Then other providers should treat the chronic anal fissures with topical pharmacologic agents known as calcium channel blockers or nitrates. This calcium channel blockers or nitrates, they act by secreting nitric oxide, which is a smooth muscle relaxant, and this causes the relaxation of the internal sphincter, and this causes the relief of pain. And also it is added with 2% lidocaine or xylocaine, as we say, which is a local anesthetic, and the pain goes away. So gastroenterologists and other providers should refer patients who do not respond to, you do the conservative treatment, you do that taking a high fiber diet, the lifestyle modification, and then give them this ointments like the calcium channel blockers and the lidocaine combination like the Anoblis ointment we use. And most of the patients really respond to that, but those who do not respond to conservative or pharmacological treatment, you can give local injections of botox, that is the botulinum toxins, or you can surgery, you can do a lateral internal sphincterotomy. You cut the internal sphincter, the lateral two-third of the internal sphincter at the 3 o'clock or 9 o'clock position, and the patient gets a relief. Next. Next slide, please. So this is a topical nifedipine with lidocaine ointment versus active control for treatment of chronic anal fissure. At the end of the 6 weeks, the healing of the anal fissure occurred in 94.5%, and healing of anal fissure with the steroids, there is only 16.4%. Mean resting anal pressure decreased by 11%. So it demonstrates that therapeutical effect of topical nifedipine and lidocaine ointment should be extended for conservative treatment of chronic anal fissure. Next. Now we come to the third part, that the anal fistula, which also forms a part of the problem. So next slide. This is a very important slide where we see the internal sphincter muscle, then we see the external sphincter muscle, and there is the anal verge, and there is the intersphincteric space that is there, and also we see two areas, that is the supral levator ani muscle, that supralevator area, and the ischiorectal fossa. And this is a very important, because the anal glands, the idea of this anal fistula appearing is at the dental line, where these anal glands are circumferentially placed. 7 to 8 anal glands are there. They are placed in the intersphincteric plane, and the infection of the anal glands leads to these perianal abscesses, and these perianal abscesses, if they are not clearly drained, they lead to the perianal fistula. And this intersphincteric space is most important, where this perianal fistula starts, and most are the intersphincteric fistula. There can be small superficial fistula. The low anal fistulas are there, the high anal fistulas. There is extrasphincteric fistula and the transsphincteric fistula, which goes through both the sphincters. Next slide, please. A fistula is defined as an abnormal communication between the two epithelial surfaces. It is a communication between the anorectal canal of the perianal skin that is lined with granulation tissue. May, however, the chronic infection which may discharge continuously or intermittent through an opening onto the skin. The opening under the skin is what we tell the external opening of the fistula. And what is important is to identify the internal opening of the fistula. And when you can identify the tract of the fistula, the treatment is either you plug the tract, either you excise the tract in fistulotomy, or you use the laser, or you use at this present moment stem cells. Next slide, please. Intermittent discharge is usually caused by cyclical accumulation of an abscess with associated discomfort and pain before relief from the discharge. When that discharge comes out, the patient is totally pain-free and is doing well. And this cycle goes on. Sometimes the fistulas, the abscess is formed there and there is pain. Patient takes the sea bath, takes the antibiotic, the fistula's mouth opens, the pus drains out, and the patient is pain-free. Next slide. The prevalence of fistula is 1 to 2 per 10,000 people in European studies. Men are twice to be affected, and most commonly in the third, fourth, and fifth decades, with a peak around 40 years. Exact incidence in India is not known. One rural study from MP states that incidence of fistula was grossly around 8.6 per 1 lakh population, and male-female ratio was males were 12:1. Next. So this is the dentate line, and this is the anal glands. The cryptoglandular theory of the anal fistula is the infection of the glands in the intersphincteric space of the anal canal. These are surrounded, and some portion is in the intersphincteric space. And whenever there is an abscess or a fistula, the abscess, you have to drain the abscess and you have to really curate the glands. Then only can you get a clear cut the healing of the abscess. Otherwise, the abscesses will lead to fistula. Next slide. The exact cause of infection has been, but it spreads throughout the path of least resistance, creating a tract. Hence, a common presentation is an acute abscess to fails to after surgical or recurs at the same time. And this is a very, very important take. Whenever you find a patient with perianal pain, throbbing, patient cannot sit, patient, you are thinking on a rectal examination, you can feel a bulge or you can feel a induration there. This is one abscess where you don't wait for fluctuation. Along with the breast abscess, parotid abscess, this area, the perianal abscess, this is one area where on the suspicion of an induration, you do not wait for any fluctuation. In other places of the body, we wait for the fluctuation to appear, then we go for drainage of the abscess. But this is an area where on the grounds of suspicion of an induration of an abscess, you go for a incision drainage of the abscess, and making sure that you drain the abscess by Hilton's method, do the de-roofing of the cavity, and also make sure that you curate the anal glands. You curate the anal glands which lie in the intersphincteric space. Next slide, please. The conditions associated with fistula, if you have a multiple fistula or a complex fistula, always think of Crohn's disease or tuberculosis in our setting. There can be pilonodal sinuses, intraarterial suppurativa, HIV, trauma, foreign bodies, previous surgery, including ileoanal pouch surgery, radiotherapy, lymphogranuloma venerum, presacral dermoids, sacrococcygeal teratoma, rectal duplication. But in our settings, never forget tuberculosis, never forget Crohn's disease. And you have to think of previous surgeries also. If there is a history of previous drainage of previous abscess, it is a cause of a recurrent fistula, as we have seen in the earlier slides. There is next slide, please. So it is a low fistulous tract that passes through few or no sphincter and is relatively close to the skin. This is a low intersphincteric fistula, the transsphincteric fistula. Next is a high fistula. Next slide, please. High fistula describes the tract that passes through above amount of the muscle. Its roots are more complicated and further from the skin. These are high intersphincteric fistula, high transsphincteric fistula, suprasphincteric and extrasphincteric fistula. Next slide. This is the most important slide, I think. The type 1 is a superficial fistula, which tracks under the external anal sphincter. Type B is an intersphincteric fistula. This is the most common type of fistula that we commonly find, that starts in the intersphincteric space, bulges to the sphincter and produces into the skin. Then there is a transsphincteric fistula, which goes to the both the internal and the external sphincter and presents into the skin. There is a suprasphincteric fistula, which goes above the uh, internal sphincter over the puborectalis muscle and penetrates the skin before tracking down to the skin. And an extrasphincteric fistula tracks and penetrates the muscle into the rectum. So what is important in this is that when you are going to treat a fistula, next slide please, after considering whether the fistula's tract is high or low, additional the secondary tracts or residual abscess. So what is important is to find out whether it's a simple fistula, whether it is a straight or it's a single tract or it is a multiple tract with an underlying abscess, then becomes a complex fistula. And this has to be explained to the patient in particular, because fistula surgery has two complications. One is you have for the fear of preserving the sphincter, you have cut less and there is recurrence. And number two, when you have boldly cut the sphincter, you have eradicated the fistula, but you have caused incontinence. You have cut enough muscles and the patient is incontinent, cannot hold his stool. So this complications has to be explained to the patient when you are going to treat a fistula patient. So examples of complexity such secondary tracts extend above the levator muscle, supralevator, suprasphincteric, and those may extend in similar circumstances. And there is sometimes they can extend as a horseshoe shaped around the circumferential manner, and these are very difficult to treat. Next slide, please. And you have to consider Crohn's disease, previous surgery, radiotherapy, cancer, which make the fistulas more non-healing, and there is more chance of incontinence. So the fistula with a low primary tract may be complex and difficult, and secondary tract specific disease underlying the fistula sphincters have been previously operated on. Next slide. So symptoms are, as we said, perianal discharge, pain, swelling. When the external opening gets blocked, there is pain, swelling, and then there is perianal discharge, the pain goes. There's bleeding, diarrhea, skin excoriation, then there is a external opening. Next. So it is a part of the differential diagnosis in patients presenting with chronic or recurrent pain, lump or disease. Recurrent abscesses or failure of healing at incision and drainage obviously indicates the presence of an anal fistula. You have to take history of perianal sepsis, previous surgery, radiotherapy, trauma, obstetric trauma or otherwise, and determine the patient's baseline level of continence. Next. Abdominal examinations will be normal, but you have to exclude any intra-abdominal pathology. You have to document the external openings, the internal openings, then recurrent swellings and pain under a scar indicate that there is opening. And the external openings from the anal verge, you have to say at a 3 o'clock position or a 6 o'clock position or a 12 o'clock position. With the patient in lithotomy position, the anterior clock phase margin is the 12 o'clock. That way you make the pictures of your fistula and you plan your treatment. Next. Palpation of the perianal area with a finger. You can feel a palpated tract like a cord-like structures indicating digital rectal examination of the finger. That may appear the induration of the internal opening like a grain of rice. Digital examination higher up may also show bogginess or indurations with chronic sepsis. Next. a full history and examination is required. Examination of the perianal skin tract, the digital rectal examination, the external opening also guides the surgeon how you will plan your surgery. And in that, next slide, please. You have the Goodsell's rule, which go when the fistula is posterior to a line joined through the 3 and 9 o'clock position. It will always have an internal opening in the midline posteriorly. And fistula anterior to that will have an opening radial into the anal canal. But sometimes this the fistulas do not follow the Goodsell's rule, as we see by our investigations of the MRI fistulogram, which sometimes show that there are different tracts, multiple tracts, and the anterior fistulas, which are anterior to the line joining 3 o'clock, 9 o'clock, they are more difficult to treat. Next. Anal ultrasound is cheaper but operator dependent, but I think it has got though it can say details about the sphincters, but it doesn't have much value. The much value is the next slide, please. MRI is the gold standard for imaging the fistula's anatomy. It will give you a best soft tissue resolution. It can tell you the underlying abscess. It can tell you the multiple tracts, the secondary tracts, and you can plan your surgery. And also with the MRI, another important thing that is important is examination under anesthesia, where under anesthesia, in a patient in lithotomy position, by injecting hydrogen peroxide and methylene blue into the external opening of the fistulous tract, you can really find out the tracts and also identify the internal opening and accordingly plan your surgery. Next. So there are many management options for fistula. There is set-on, there is fistulotomy, then there is sphincter saving methods like fibrin glue, fistula plug, endorectal advancement flap, the ligation of the intersphincteric fistula tract, then stem cells, and defunctioning colostomy. So we'll go one by one. Set-on is next. A set-on is a thread that is pressed into the fistula tract, tied between the internal and the external openings of the fistula tract. This is done in a high transsphincteric fistula where division of the whole fistulotomy will cause damage to the sphincteric muscles and will cause incontinence. Set-on maintains the fistula tract, allows drainage, and prevents the perianal sepsis. It reduces inflammation, allows establishment of a well-formed tract. So it is in difficult fistula, set-ons really come out. Next slide. Next, please. So this is a way you have put silk set-on. Next is the fistulotomy. It describes the division of the superficial tissue, thus laying open the fistulous tract. It is the most effective method in a low fistulas. There is no risk to continence or recurrence. Next. Now these are sphincter saving methods. You can do it by feeling the fistula tract. You can feel the fistula tract with fibrin glue or fistula plug. Fibrin glue is a combination of fibrinogen, thrombin, and calcium in a matrix, which is injected into the fistula tract. When the patient is under anesthesia, heals the fistula tract by inducing clot formation within the tract, then encouraging the growth of collagen fibers or healthy tissue. Healing rates are variable, 31 to 85%. Then there is a fistula plug, which is manufactured for porcine small intestine. It is resistant to infection, does not elicit foreign body reactions, encourage the cells to populate, ultimately causes the fistula tract to heal. Resultant closure is 54%. But next slide. Then you have the ligation of the fistula tract. You can ligate the intersphincteric fistula tract by the lift procedure. A skin incision is made between the internal and the external anal sphincter. You identify the fistula tract, expose the tract, tie the inner opening of the fistula tract. The success rate is between 57 to 94%. Endorectal advancement flap. This is advancement flap aims to stop the fistula tract communicating with the bowel wall and cover the internal opening with anorectal wall. The procedure involves dissection of a partial thickness flap of the rectal wall and to cover the and advance it on a pedicle blood supply to cover the excised internal opening. The success rate is around 30%. Next. Now the newer method is stem cells. Use of stem cells is a novel treatment. Stem cells plus fibrin group was compared with the fibrin glue alone group, and the healing rate was 71%. The recurrence rate was 17.6% in stem cells at 1 year. Defunctioning colostomy is what we do in a very high fistulous tract. We do a defunctioning colostomy. We divert the stool. We treat the fistulous tract. We help the fistulous tract to heal. We do a loop colostomy, sigmoid colostomy, and to divert the stool. And when the fistulous tract has healed, then we again put the colostomy back. So this is one of the procedures. Another are the obliteration of the tract. You can do by the obliteration of the tract, you can do video assisted anal fistula treatment, where you can obliterate the tract by irrigation and diathermy to destroy the tract and the direct vision using a fistulotome, a stapler, and a advancement flap. You can use fistula laser closure by a radial emitting laser probe, but these are all in the development and these are being done. But the results, as we say, in a fistula, in a complicated fistula, is again, fistula is a graveyard for the surgeon. So I think, thank you very much for listening to me and giving me time, and thank you Samat Life Science for giving me, and thank you colleagues for being patient in hearing me out. Thank you. If you have questions, please.
Thank you, sir.
Yeah. Thank you so much, sir, for such a nice presentation and such an elaborative presentation on all the three diseases. Sir, you want to have a water break?
No, it's
Because
all right.
okay, sir. So there are a few questions. I will take it one by one. Dr. Chaudhary want to ask, how does sitz bath helps in piles?
In case of third degree piles or a fourth degree piles, the seized bath will help in decreasing the edema, and it will also decrease in the increased anal sphincter tone, and that helps in shrinkage of the piles also. Along with the, obviously you have to give the micronoise purified flavonoid fractions, and also do the conservative treatment, and ultimately in a grade 4 piles you have to do the surgical treatment.
Okay. Dr. Samir Ranjan want to ask, when a patient encountered with both grade 3 hemorrhoid and chronic fissure in ano, what is the best approach? Should we go as a lateral sphincterectomy should be done first, or closed hemorrhoidectomy should be done first? Or can two procedures be done in same sitting?
I think in my presentation I have also said that although you have the investigations, also and you have investigated, you have seen the patient in your chamber, or after being admission, the best position to investigate, I mean, to plan your surgery is after you have anesthetize the patient in a complicated case like which have a chronic anal fissure as well as a grade 3 hemorrhoids. Here, after giving the saddle block or the spinal anesthesia, the patient in the lithotomy position, you can do you can see the sentinel skin tag, you can do a lateral sphincterotomy, and if the piles mass are there, if there are circumferential piles or a single piles mass or two piles mass, you can do it at the same sitting, provided you maintain a skin bridge between the two piles mass. That is very important to prevent anal stenosis. I think that is the only thing that you can do the two procedures together, yes, but but what will be important is to maintain the skin bridge.
Okay. Dr. Raghav want to ask what is the role of calcium dobesil in piles? How it helps?
Calcium dobecylates in the piles will also decrease the congestion of the venules, and as a result of which it will cause shrinkage of the piles mass, and also it can cause a little calcium dobecylate. It can cause a little, has a laxative action.
Okay, sir.
So
Dr. Debayan Chaudhary want to ask, there is one cream available which is a combination of beclomethasone, lidocaine and phenylephrine. So shall we prescribe beclomethasone in the treatment of piles?
I think it is better to avoid steroids in case of piles. Steroids, I don't think has a much a role. It has been proved that you can use a calcium channel blocker. It can be nifedipine, which releases nitric oxide, which is a smooth muscle relaxant and causes the internal sphincter spasm to go. And steroids, as such, do not have that role, and I don't think steroid creams have much role in that treatment.
Okay. Dr. Firoz Chaudhary want to ask, what is the management of reactionary hemorrhage after hemorrhoidectomy?
Well, this is a very important question. If your hemorrhoidectomy you have done, and what is important is if you have done a closed hemorrhoidectomy or if you have done a open method, the Milligan Margon method, then what is important is, in my case, what I do in when I am ligating the pedicles, when I dissect down up to the sphincter, ligating the pedicles I tie doubly, and I keep a suture that is long. It causes an inconvenience to the patient sometimes because of the suture, but it is a safety profile for you. Then if you have a bleeding reactionary hemorrhage in the evening, in the wards, when you have gone, the sister says that the bleeding is excessive, you can take the patient to the OT, because then again, doing anything in the ward or the patient's bed is very difficult. You have to really reassure the patient, and if you think the bleeding is excessive, you have to take the patient to the OT. And if you have that piles masses, you have the three piles masses that you have excised, you can put the put artery forceps, you can draw the piles, the where you have tied the apex of the piles masses, where you have tied, you can see if there is bleeding. You can again cauterize the bleeding or tie, and you can save, but provided that there is sometimes when there is no facility as such, you have no anesthesia at night and there is bleeding, for a temporary measure, you can put in a Foley's catheter. You can inflate the balloon to 30 cc of water, give a traction on the dented line. It is painful. You have to sedate the patient with pethidine or Fortwin. And this is a temporary measure. You can wait for 6 hours or 10 hours till the next morning, and you can see, reassess after deflating the balloon. And if you see that the bleeding is still continuing, then you have to take him to the OT and uh, redo your or tackle the bleeding.
Okay, sir. Sir, what are the indications and contraindications for sclerotherapy in hemorrhoids?
I think the indications of the sclerotherapy is, you have to see whether the piles mass is second degree and the early third degree. If it is already third or fourth degree hemorrhoids, then sclerotherapy will of be no use. So you have to really understand that you are treating a second grade 2 or grade 3 hemorrhoids, early grade 3 hemorrhoids, and whether there is patient do not have any bleeding disorder or is not on an anticoagulant, or patient is you can hold the anticoagulants for a few days, and you can go for a. And what is important in this injection sclerotherapy is where you give the injection. When you are giving that polygonal form, when you are giving it in the submucosal plane, when you are giving to these venules, you are really targeting that area. You'll see a blanching, and the patient will not feel much pain because it is above the anoderm and supplied by the parasympathetic plexuses. And if your injection is in the correct plane and you have given the polygonal injection well, I think the patient will the things will the grade 2 or grade 3 piles mass will shrink.
Dr. Salil want to ask, in fistula, plain MRI should suffice or contrast MRI is needed?
I think contrast MRI will be the best bet. In case of low fistulas, which is maybe a very low fistula, you can identify the external tract and the internal tract, you can see. Then plain fistulogram will do, but MRI will help you in a fistula that is intersphincteric fistula, that is away 2.5 centimeter away from the anal orifice, or a little outer, or in a previously drained perianal abscess. I think contrast enhanced MRI is the best option to plan your surgery, whether it's a complex fistula, whether there is underlying abscess, whether there are multiple tracts or not.
Okay. Dr. Tapan Kumar want to ask, in lateral sphincterectomy, you cut external sphincter or internal?
Internal.
Okay.
We give an incision at the intersphincteric groove. Patient is in the lithotomy position. An incision in the intersphincteric groove. We a longitudinal transverse incision is given, and then we pick up the hypertrophied internal sphincter using a mosquito forceps. You use the mosquito forceps, pick up the internal sphincter, then with a diathermy you cut the medial two-third of the sphincter, and you keep that area open for drainage.
Dr. Ashish Chakravarti want to ask, in portal hypertension induced piles, are piles regress after introducing the treatment of portal hypertension, or is it necessary to go for the surgery?
I think in portal hypertension, always the surgery has to be. If only go for surgery when your hands are tied or bleeding is severe, and make sure you have a harmonic device or anything, because in portal hypertension you have to treat the basic disease. That is the because all the areas of the portosystemic shunts are engorged, and their bleeding can be torrential. So if when you treat the patient's other condition, and you can go for the conservative treatments like the injection sclerotherapy and everything, and when all this fails, then obviously when your hands are tied, then only go for that surgery, explaining the high risk to the patient and explaining all the complications.
So Dr. Ashish Chakrabarti has one more question. High fistula cases, any other alternative for defunctioning stroke?
Huh? I don't get you.
Uh,
Can you repeat the
high,
question?
yeah, sure, sir. High fistula cases, any other alternative of defunctioning stoma?
In high fistula cases, now we are using sometimes a phylac or fistula leisure closure, which is causing less morbidity. But we have to really find out how much is the fistula tract, and where we are going to but defunctioning stoma is a last resort, and you have to take consent from the patient. You have to explain to the patient, and the morbidity is quite high because you have to do a defunctioning stoma. You have to treat the fistula at the same sitting, and then when the fistula heals, which may be after 6, 8, 12 weeks, then you can return the colostomy back. And that also, because in fistula you are always trading on a high ground of anal incontinence. If you do more, if you do less, there is a chance of recurrence.
Okay. Dr. Firoj, I think this is the last question now. Dr. Firoz want to ask your experience with medicated ceton.
I do not have much experience with medicated ceton. I have used steel wares, or I have used monofilament nylons or prolines as cetons. But medicated cetons I have not used, but it has been used, and in some cases of difficult fistulas and transfictoric fistulas, they have they are reported to give good results. But again, results vary from person to person.
Okay, sir. Sir, that was the last question of the session. Thank you so much for taking the session and answering the question and answer so patiently. I am sure all our attendees would have been benefited with your session as well as question and answer. Now I request Mr. Devashish to close the session.
Thank you very much, sir, and thank you everybody for giving your patience, and thank you very much, sir, for giving us your valuable time from your busy schedule and excellently explaining each and every points related to the subject and sharing your rich opinions and experiences with us. Thank you very much, sir.